Hello, and welcome to this episode of the Neurology Video Journal Club. My name is Brian Callaghan. I'm a professor of neurology at the University of Michigan, and I'm very excited to be here with Dr. Quigg, also from the University of Michigan. I'll let her introduce herself.
Kellen Quigg. I'm chief resident at the University of Michigan. I'll be staying here for my neuromuscular fellowship next year. Happy to be here.
Great. And today we'll be discussing an important article in the Journal of Neurology on hastening the diagnosis of amyotrophic lateral sclerosis, or ALS, written by Doctors Mitsumoto, Kasarkis, and Simmons. And with that, I'll turn it over to Dr. Quigg to kind of discuss the article in general.
Thanks, Dr. Callaghan. So this was a great figure, I thought. So this describes sort of the hypothetical illustration of the disease progression in ALS and also some areas where we could intervene. The premise being that the diagnosis of ALS is often delayed by a multitude of reasons and sometimes can take, or average takes over a year for diagnosis. And over the last 20 years, despite a lot of efforts to shorten this time period, not a lot of change has happened. So they start here by first sort of using sort of some animal models and other sort of preclinical data for pointing out that a lot of the changes that occur in ALS happen before clinical manifestations occur, so that by the time they present with symptoms to their GP, to a neurologist, an orthopedist, whatever it may be, a lot of the damage of the disease is already started. And then once the disease has sort of reached a critical threshold, at which point symptoms manifest, the decline then it accelerates and becomes more rapid. And so at that point, when we're trying, that's when people are getting diagnosed. That's when we're starting to give people treatments. That's when we're looking at clinical trials to start implementing therapeutics. That potentially we're already too late. And that if there's ways to do it sooner, that would be better. They use a couple of post-hoc analyses from methylcobalamin, edaravone, the sodium phenylbutyrate trials, where it looks like people who had a shorter duration from symptom onset to diagnosis or at least enrollment in the trial and receiving medications tended to do a little bit better. And so how do we, as a community, accelerate the diagnosis, get people into multidisciplinary clinics, neuromuscular specialists, and then really get some of these treatments into patients to make a difference? And so this is what they've proposed. And I really love this figure, especially because they've highlighted the progressive, painless weakness. They've also sort of noted dropped head, family history, bulbar symptoms, although typically people with bulbar symptoms, trouble breathing, trouble swallowing, their diagnostic delay is a little bit shorter because people say, oh, this must be neurologic. And then sort of the more generalized malaise, weight loss, things like that. But really highlighting the progressive asymmetric painless weakness to sort of jump straight to sending these people to a neuromuscular specialist, that if they sort of meet these threshold criteria, when is it reasonable to sort of go right to the subspecialty clinic rather than skipping through to an orthopedic surgeon or things like that. Of course, trouble swallowing can be ENT related, GI, a lot of these are really vague. And so I think they do a really nice job pointing out, when is it the right time to just skip straight to a subspecialist? When is it the right time to go straight to a neurologist versus sort of stopping? And that helps get people into clinics, get diagnosed sooner, get treatment sooner, and get a lot of the multidisciplinary care that they need. One of the things I think is really interesting that they pointed out was using the Gold Coast diagnostic criteria for diagnosing people with ALS. This allows, rather than a combination of upper and lower motor neuron symptoms, which then makes people who have like progressive muscular atrophy who may not have the upper motor neuron symptoms and then have an even longer delay in diagnosis, the Gold Coast criteria allows you to make a diagnosis of ALS purely based on lower motor neuron symptoms and EMG changes. So this also then you don't have to wait for a patient to develop upper and lower motor neuron symptoms. You may be able to sort of get them to meet criteria sooner. With that, I'll go ahead and I'll turn it over to Dr. Callaghan. What initial thoughts? What were you thinking? What do you think about this paper?
Yeah, I think it makes a really good point, which is that we know patients with ALS take a long time to get diagnosed, and it's on the order of a year, and we really haven't made a lot of headway in that. And so, I think they point that out. They point out the fact that probably treatments need to be on the early side if they're going to be effective, which I think is true. And then they propose some solutions too. So, I kind of like all those things, because we do need to figure out ways, how do we make this system go a little faster. And, I think, from, about the, when we're talking about, treatments and making it earlier, we have an example, recently with Alzheimer's disease that, the trials kind of went earlier and earlier and earlier, now into MCI, mild cognitive impairment, and mild dementia. And those were the first trials to have any kind of efficacy. While they're not perfect therapies, I think for the first time we're seeing Alzheimer's have a treatment that improves cognition. And so that's very exciting and might apply also to ALS. And so, I think that they're right that, we need treatments earlier if we're going to be effective. And to do that, we need patients to get diagnosed faster.
Agreed. We wouldn't be having a journal club, though, if we only had great things to say, right? We have to sort of talk about this and see, are there other ways? What other things do we need to be considering? The paper talked about using neurofilament light chains for sort of early diagnosis and being sort of a helpful adjunct for people who have symptoms that are concerning for ALS, and then also having elevated neurofilament light chains to sort of make you more confident in a diagnosis. I guess my questions in the practical world is, at what point in symptom presentation in the diagnostic workup do you order these tests? When is the right time to test? And if every patient with an elevated neurofilament light chain gets sent to an ALS multidisciplinary clinic, are delays in getting into the clinic going to extend?
Yeah, I mean, you raised some great questions. I think it's important to point out that, it's exciting that we're for the first time talking about some diagnostic biomarkers that might be helpful. And neurofilaments, the different types of neurofilament, in the CSF have been studied the best, but also maybe in the serum as well. Although I think that's going to be a big difference. It's, getting CSF, is also probably going to lead to delays, and is, not everybody gets that very fast. So serum would be far better than a CSF marker, but there is some promise with the serum markers too. And I think the key is that these articles that are referenced in this paper show that they have really good diagnostic characteristics, and they're really well done studies. But at the same time, there's more questions, and a lot of times we don't put our diagnostic tests up to the same rigor we do our medicines. And so I think we need to do a lot of study to answer the very questions that you bring up. We need standardized labs so that everybody's, talking about the exact same thing, standardized thresholds for when to think it's ALS, ideas of when to study it. And we could do studies where we randomize, some people get neurofilament levels and others don't, and see how that affects diagnosis. Does it make it earlier? Does it make it better? Does it lead to more false positives and extra consults? So I think this is really promising, but like always, I think there's more to be learned.
Agreed. Another question that is near and dear to both of our hearts. So I had mentioned that the authors talk about some of the sort of post-hoc subgroup analyses of clinical trials with edaravone, methylcobalamin, and the sodium phenylbutyrate drug in particular. And that part of implementing their changes for an earlier diagnosis is good because it gets people into clinic to receive these medications in particular, and that therefore they receive the benefit from those medications. Dr. Callaghan and I are always the skeptic and always, really eager for really great, meaningful clinical changes. Do you think that they're maybe overselling the benefit of getting into clinics earlier for those specific treatments?
Yeah, that's a great point. I mean, with ALS, we haven't had very good treatments. For the longest time, we just had Riluzole, and now there's some new FDA-approved medicines as well. And I think as a field, I think we have to admit that we don't really have great treatments at this point. So obviously, once we do, there's an even greater impetus to get people diagnosed and into clinic early. But at this point, these medicines are relatively controversial. For example, Edaravone is approved in the United States, but not in Europe. And the new sodium phenylbutyrate medication had a phase 2 study, but not a positive phase 3 study. So again, approved here, but not in Europe. In Europe, they're doing a phase 3 study. So right now, unfortunately, we're still in an era in ALS where we don't have proven therapies, and I think we do need to kind of own that. Because once a new amazing therapy comes out, we need not people to confuse the two, and make sure that we are rushing people to get into treatments and trying to get them qualified quicker. But right now, I don't think we're really at that space, and that might be part of the reason that diagnosis is slow. But my guess is there's lots of reasons for that.
Yeah, something that I thought that they sort of undersold a little bit is the benefit, not just of getting in for these treatments, but the benefit of getting into a multidisciplinary care clinic. So a lot of the ALS clinics have teams of nurses and pulmonologists, palliative care specialists. A lot of them are, connected through philanthropic groups, things like that, to increase resources that the patients can have to help expedite sort of the transition into, Medicare sort of support for the family. There is some data that it is good for survival. And I think it helps patients to be part of that community. And so even though a lot of times we'll talk about this, they have to travel a bit to get to a clinic, I still think that that's a piece that's undersold, especially in encouraging patients who may have this diagnosis to get in and get seen sooner. So that was another piece that I just really figured I would emphasize while I'm given my moment to.
No, I think you're quite right. I mean, when patients come to the clinic later in the disease and we have to deal with lots of major decisions all at once, it is really difficult. And I think it really helps to have different stages where you're talking about different things, not rushing into 3 or 4 major life decisions all at once, let alone all the other benefits of a multidisciplinary clinic. So I completely agree. Earlier diagnosis is better. Getting people into clinics early is better. I just wish we had better therapies to offer them once they got there.
Absolutely. The authors sort of compared ALS to SMA, where now there's a lot of genetic screening early on, and then they immediately get into clinics and get these fabulous treatments, where, we sort of felt, well, maybe that's not the best option. There's not a foot or the best comparison, rather. There's not like a nice little foot stick where you can test genetics for ALS and get the diagnosis. And we don't have the same types of treatment at SMA yet. They reference MS, which you and I have discussed sort of at length, that, well, maybe this is a better disease that we should be comparing people to, where it certainly can be mistaken for other things. The delay in MS is still, up to 8 months, 6 to 8 months, up to a year sometimes. And they've really made a lot of strides in MS. So what kinds of things, I guess, do you think that we could draw from MS to pull over to the ALS world?
Well, I think it shows you just how difficult this is. In contrast to ALS, multiple sclerosis has several new therapies and some that are highly effective. We started out with medicines that have relatively small effects, and now we have ones that have really big effect sizes. So, much more treatable than ALS at this point. I think that's clear. But it's still really hard to get diagnosed with MS quickly. It takes, months. And I just think that shows you like our system is set up in a certain way. You see your primary care physician, you see a neurologist, then you see a specialist, and each of those adds months into the process. And it's really hard for primary care physicians to diagnose things that are, super rare. I mean, MS is super rare, ALS is super rare. From their, from our perspective, it's not. They all come to us, but when you're looking at the epidemiology of it, a primary care physician might not see ALS but a few times in their career. So it is really hard. And early on, it's hard to make the diagnosis. All these things become clearer with time. So we're always kind of lucky that we have some of this delay because it makes diagnosis easier in that way. So I think we kind of have to admit that, it's our system is set up for these delays, especially for diseases like MS and ALS, where it's not so clear in the beginning, and there's a lot of potential other diseases that could mimic that. So I think we need some kind of creative ways to redesign the system if we're going to shorten the diagnostic delay. And I completely agree. SMA is a little different because, genetics, is a bigger thing. We're talking about younger people too, where it's a little more clear often that it's genetic. ALS is, inherited in a small degree. I mean, more than we used to think. Now with C9, we know that, at least 10% of sporadic patients have C9, and even more have inherited ALS. But most patients still, the genetic diagnosis isn't going to really be the thing that makes diagnosis earlier. So yeah, and again, I think also in contrast, MS and SMA do have much better medications. Just highlighting we need better medicines in ALS, and I don't think anybody would disagree with that.
Something that I really loved about this paper was that they did sort of put forth a proposal, to say what are some of the red flags. And I know there are other groups studying a lot of the ALS red flags that should sort of raise the awareness of a primary care doctor or any provider who's seeing this patient to get them to a neuromuscular specialist faster. And then, as we discussed, sometimes even when you see the neuromuscular doctor, it can be really hard, and you still need time to wait to make the diagnosis. So one of the other unique things that they proposed that I had referenced earlier is this Gold Coast criteria for diagnosis, where you can use the lower motor neuron predominant scoring criteria to be able to diagnose people with ALS faster. So that way, if you've taken out some of the hop, skips, and jumps you make to all the different subspecialties or, different disciplines of medicine altogether, that at least once you get to the neuromuscular doctor, you don't also then have to wait and wait and wait. I've mentioned earlier, well, what are we going to do when more and more people are getting sent in for things that people maybe are considering could be ALS? Is that going to slow? They've looked at some people that even once they've been referred to a neuromuscular clinic, it takes months to get in. I know here that we do a pretty good job of expediting these folks into our clinic, but it's hard to do everywhere. And especially, different countries have different healthcare systems that may make it easier or harder. What do you think specifically about the Gold Coast criteria and how that sort of changes the diagnosis of ALS?
Yeah, well, I mean, the authors talk about, how the GOLD criteria increases sensitivity, which is great. But, that always does come at the expense of specificity. And so, I don't know if, which is the best criteria to use. I mean, that might be the way to go. Obviously we have the Ellis-Ferrell criteria as well. But what I do know is that, false positive diagnoses are things that we have to talk about, especially if we're talking about trying to move up diagnosis. Because moving up diagnosis, could make you try to diagnose, earlier without all the information. And, we know from large registries that, there's about a 5% a false diagnosis rate in ALS. I don't know that I've seen anything recent, so I don't know if that's a number that's going up or down. But 5% is a pretty big number, and giving someone an ALS diagnosis that doesn't have it is also an issue, and I've seen that play out quite a few times in my career. And and it's not an easy thing. So I do think we do have to balance these things, especially when we don't have the best therapeutics. That there's not always a rush to diagnose. You do have to get the diagnosis correct. So I don't know that I have the answers, but I do know there's this inherent trade-offs of sensitivity and specificity, and false positive diagnoses and early diagnoses. And I think we just need to think about these issues and address these issues. And it's not just one side. We have to get people diagnosed super early. We also have to make sure we get the diagnosis right.
Yeah, I mean, I think it's also really important when you start to think about clinical trial enrollment too. You don't want to be offering investigational therapeutics to somebody that doesn't have a disease, both sort of for the ethical reasons of that and also for what it means for the trial integrity. And so it's a bit of a balance, getting people in, getting the diagnosis, getting on this multidisciplinary care I've been raving about, but also being very precise, making sure that we're not, like you said, it's really important. You don't want to get this wrong.
And I would point out that multifocal motor neuropathy, is a big concern because it's treatable in a very different way. And it can have obviously conduction block, which is really helpful, but there are cases without conduction block, and our EMGs are just, and nerve conduction studies are limited in its ability to pick up conduction block. And so because of that, it can, we don't want to miss those patients either. We know those lower motor neuron only patients are particularly the ones that give me the most diagnostic uncertainty. When there's upper motor neuron signs or bulbar signs, it becomes much more clear.
Yeah. Well, and I think, going back to the neurofilament biomarkers, right? There's a lot of biomarkers in the works now that I think are really, really exciting. And I don't want to undersell those too, that can help sort of be complementary features to that. So, I think here we are saying it's, been 20 years and we haven't found a way to hasten the diagnosis yet, but there's a lot of really, really exciting things coming out that I think will be wonderful complements to this. What other things do you think sort of limit the ability for people to get in or to get a diagnosis of ALS faster? Some of the things I was thinking about with the timely paper you just wrote is the distance to a subspecialist. What are your sort of thoughts? You want to tell us a little bit about the data that you have to support this?
Yeah, well, because we had an article just come out in Neurology, I think we should probably discuss that, which we were looking at, how people have to travel far away to see a neurologist. So 1 out of 5 people have to travel greater than 50 miles. So it is a pretty big travel burden on patients, and maybe not surprising, being in a rural area, you have to travel more. There's less neurologists around. You have to travel more. But something we weren't really looking at or looking for was, specific diagnoses. And maybe it shouldn't have been surprising, but ALS and different types of neurocancer are really the diagnoses that have to travel way farther than all other diagnoses. And so it just shows you that there aren't a lot of ALS centers and neuromuscular experts that are comfortable with ALS. And so those patients, have to travel the most and, also have the hardest time traveling. And I think that, has an inherent difficulty in trying to hasten the diagnosis. It's not like patients, that I diagnose are usually coming from a few blocks away. Sometimes they're coming from hours away. Michigan's a very big state. Some people can travel up to 10 hours in car to come see us. And so how do we get diagnosis to those patients earlier? And I think it brings up that we need kind of innovative care models. If the model is going to be see a PCP, see a neurologist, see a neuromuscular specialist, I think we know how that plays out. These authors try to point out a very cool way is just maybe skip a step here or there if we can manage it. And I think that's smart. That's a really good way to do it. But I think we need to think beyond that. Can we have, ALS specialists available to, have, local doctors contact them to maybe, that's a patient that needs to be seen right away. That patient doesn't sound like they have ALS or needs more workup. How can we help people, outside of the traditional model of come see me in the office or even a teleneurology visit? Because it could be something much shorter than that to guide local physicians. Unless we, quadruple the ALS, physician workforce, it's going to be really hard to have ALS centers, in all the places people need them.
Yeah. The group out of Emory sort of studied a little bit about how the delay in diagnosis for African Americans is an extra 6 months on top of everything. A lot of other factors, including, and the authors referenced a lot, people who say, oh, I'm just getting old, that's why I'm dropping things, or, that's why my muscles are shrinking. So I think also, the psychology of the patient bringing themselves to medical attention, and, what are our biases on, you're the first person to see a patient, you don't want to tell them they have ALS or start to bring that up if you're really not sure, it's not within your realm. I think there's a lot of different reasons that are hard to quantify for why there are also delays. But I think, like you said, sort of finding creative ways outside of the traditional, oh, I put in a referral, you'll get a call from the clinic and come and see me on a clinic day. A lot more outreach, telemedicine, they've talked about sort of a lot of the awareness programs, I think are also going to be really helpful.
Yeah, no, I think you make a good point. And I think, our conversation in general points out that, like these authors said, this is a problem. It's a consistent problem. We know what the problem is. We know the length of the problem. But it's also a hard problem to solve. Patients are very far away from the providers. There are multiple layers to get through, in our current kind of system. We're not great at like shortening these intervals. And then there's inherent trade-offs of, false diagnoses versus early diagnoses. And then, what we really need is better therapies, and I do think that we would see, the diagnosis window shrink a little bit, like in MS, get down to maybe that 8-month time period, if we had better therapeutics than we currently have. So yeah, the nice thing is there's lots of things to study, lots of things to improve. And, I look forward to seeing over the years how this field changes. And it's changed a lot in the last 15 years that I've been doing it. And, I look forward to seeing how much we improve in the next 15 years.
I'm ready to hit the ground running. All right. Well, thanks, Dr. Callaghan. This was really fun. I agree. This was a great article and a lot of exciting things to think about. So thanks for the invitation.
Yeah, thanks, Dr. Matsumoto, Kasarkis, and Simmons for their great article. And, a lot of things come from this. And yeah, we look forward to seeing how this plays out over the years to come. Thanks, everybody.